Welcome to the deep dive. Today, we're really tackling something complex based on your requests. We're aiming for a mastery-level look at the surgical anatomy of the mouth.
That's right. This isn't just naming parts. We're going deep into the structure, the development, the things that can go wrong, all geared towards that elite surgical understanding.
Absolutely. It's about connecting the dots,
Yeah.
how structure dictates function, how embryology leads to pathology.
Exactly. We've got sources covering everything from the earliest fetal stages right through to clinical practice. We're aiming to build that high-stakes mental map you need.
Okay, so mission overview. We're mastering the mouth structure, its blood supply, which is quite specialized, and those nerve pathways that are just so vulnerable.
And this understanding, it directly supports those really demanding procedures.
Right. Things like cleft lip and palate repair, obviously,
Okay.
but also submandibular gland surgery, removing calculi.
Orthognathic surgery, trauma repair for the maxilla, and mandible. It's all underpinned by this anatomy.
And let's not forget the everyday, but still crucial, application in dental anesthesia. Getting that right depends entirely on knowing this stuff cold.
And to truly master it, you have to start at the beginning. You need to know how it should form to understand what you're fixing when it doesn't. So embryology first.
Makes sense.
Okay.
Okay, let's set the clock back. Day 14, you mentioned this is kind of the starting point for the oral cavity.
Yeah, day 14 is key because that's when the precordial plate appears. It's this thickening of the endoderm, basically signals the head end.
And that leads to the oropharyngeal membrane.
Directly. Think of the oropharyngeal membrane as like a temporary wall. It separates the early mouth, the ectoderm part, from the primitive pharynx, the endoderm part.
So it's the initial boundary, situated in that shallow dip, the stomodium.
Precisely. And surrounding the stomodium, you've got the 5 key building blocks starting to emerge.
The 5 prominences.
Right. One frontonasal process, FNP at the top, then the paired maxillary prominences, MXP, and the paired mandibular prominences, MP below. These 5 structures are going to form, well, pretty much the whole face and jaws.
But that initial membrane, the oropharyngeal one, it doesn't stick around.
No, it's got to go. Usually by about day 28, maybe a bit earlier, it disintegrates.
Right, to create that continuous passage from mouth to pharynx.
Exactly. If it doesn't break down or if those early structures don't form right, you're looking at serious developmental problems like atresias.
Okay, so this process of things coming together, fusing, that brings us right to clefts, doesn't it, when that fusion failed?
It does. Let's trace that facial fusion process. It's quite intricate.
I bet.
So off the tip of the FMP, the frontonasal process, you get the medial and lateral nasal processes forming. These need to grow down and merge with the maxillary prominence, MXP, on each side.
And this fusion builds quite a lot.
Oh yeah, the maxilla itself, the upper lip, the nose tip, the nasal septum, and crucially the primary palate, that initial front part in the roof of the mouth.
So the specific failure point for cleft lip, sometimes involving the premaxilla too. Which bits fail to join?
That's the failure between the maxillary process, MXP, and the medial nasal process. Classic failure point.
And surgically, this isn't just cosmetic. You mentioned the orbicularis oris.
Absolutely. The orbicularis oris muscle, the main lip muscle, gets completely misaligned. Repair isn't just closing the gap. It's about finding those muscle ends, dissecting them out, and reorienting them to restore proper function, like a working sphincter.
Okay, so that's the lip. Then there's the often trickier cleft palate formation. That happens a bit later, around the 8th week.
Correct. This involves the palatal shelves. These are extensions coming off the maxillary prominences.
Initially, they hang down.
Yeah, they start off vertical, flanking the developing tongue. Then there's this coordinated dance. The tongue drops down, and those shelves have to swing upwards, become horizontal, and then fuse together in the midline, like closing a zipper.
And failure can happen at 2 points there.
Right. Either the shelves fail to reorient from vertical to horizontal, or they reorient but then fail to fuse. Either way, you've got a gap between the oral and nasal cavities.
When repairing a cleft palate, surgeons often focus on repositioning muscles in the soft palate. Which one is particularly important?
The tensor veli palatini. It's key because it forms the palatine aponeurosis, that sort of fibrous sheet in the soft palate. Getting its fibers aligned correctly is critical for proper function, sealing off the nasopharynx during swallowing and speech.
Got it. Okay, let's shift down to the lower jaw, the mandible. It forms differently. You said intramembranous bone.
Yeah, unlike long bones that form from cartilage models, The mandible forms directly within a membrane lateral to what's left of Meckel's cartilage.
And the ossification starts really specifically.
Very specifically, a single center appears for each half around the 6th week, and its location is really telling. It pops up right where the main nerve and vessel for the lower jaw, the inferior alveolar nerve and artery, splits into its mental and incisive branches.
So it almost sounds like the nerve and artery are there first, and the bone forms around them, like they dictate the structure.
That's a great way to put it. The neurovascular bundle is essentially the scaffold. The bone gets laid down around it, protecting it. This intimate link is why mandibular fractures almost always involve some kind of nerve or vessel damage.
Makes sense. Now, what about the alveolar processes? The bone that holds the teeth. You called it reactive bone.
It really is. It develops purely in response to the tooth buds, those little ectodermal thickenings that show up around day 28. The bone forms troughs around these developing teeth, sort of layering itself onto the main basal bone of the jaw.
So no tooth bud, no alveolar bone in that spot.
Pretty much. And as we'll see, that dependence continues throughout life. The tooth keeps the bone around.
Okay, let's wrap up the embryology with the tongue. Its development and nerve supply are notoriously complex, right? A mix of arches.
Absolutely. A real patchwork. The front 2/3, the anterior 2/3 presulcal part, comes from the first pharyngeal arch, specifically the tuberculum impar and the lateral lingual swellings.
So its general sensation, touch, pain, temperature must come from the first arch nerve.
Which is the lingual nerve, a branch of the mandibular nerve V3. That makes sense.
But taste is different for that front part.
Completely different pathway. Taste sensation for the anterior 2/3 gets carried by the chorda tympani, which is actually a branch of the facial nerve, cranial nerve 7th. So 2 different nerves for feeling versus tasting on the front of your tongue.
Wow. Okay, what about the back third?
The posterior third pharyngeal part is simpler. It develops from the third pharyngeal arch. So both general sensation and taste back there are handled by the third arch nerve, the glossopharyngeal nerve.
Yeah.
This includes those big circumvallate papillae just in front of the sulcus terminalis.
Okay, and finishing off the first arch derivatives, the chewing muscles and related structures. What's the motor nerve rule?
The rule is V3. The mandibular division of the trigeminal nerve supplies motor function to the main muscles of mastication, masseter, temporalis, pterygoids.
But also some others.
Yes. Crucially, it also supplies other first arch derivatives. The mylohyoid muscle forming the floor of the mouth, the anterior belly of the digastric, and that really important palatal muscle we mentioned, the tensor veli palatini.
Right, the tensor veli palatini getting V3 innervation. That's the big exception for soft palate muscles, most of which are vagus. Right, we need to remember that one.
Definitely a key exception.
All right, so we got the developmental blueprint. Now let's look at the finished structure, the clinical geography. Understanding these spaces is key for surgery.
Absolutely. The mouth is basically divided into 2 main zones.
First, the outer bit, the vestibule.
Yeah, the vestibule is that sort of horseshoe-shaped space. It's between the lips and cheeks on the outside and the teeth and gums on the inside. It's where you tuck a cotton roll.
And the nerve supply there.
Sensory nerves are branches of the trigeminal. Up top, it's branches from the infraorbital nerve, V2. Down below, it's buccal and mental nerve branches, V3.
Okay, then inside the teeth, we have the oral cavity proper.
Right. This is the main space. Its roof is the hard and soft palate.
And the floor.
The floor is essentially the tongue, particularly the anterior 2/3, and the muscular diaphragm underneath it, the mylohyoid space. This is where the big salivary ducts open up, near the front lower teeth.
What defines the back entrance?
That's the oropharyngeal isthmus. It's like the doorway to the pharynx. You can visualize it bounded by the back of the tongue at the sulcus terminalis, the palatoglossal arches on the sides, and the edge of the soft palate above.
Now, the type of tissue lining these areas is really important for surgery, isn't it? Affects how you handle it.
Massively important. But the big difference is whether it's keratized or not, which relates to how mobile it is.
So where do we find the tough stuff, the keratinized epithelium?
You find that covering the areas that get a lot of wear and tear of the gingiva around the teeth, the alveolar ridge, and the hard palate. This tissue is tough, it's protective, and crucially, it's stuck down tight to the bone underneath. Not much give.
Okay, so that's the stable stuff. What about the rest of the lining?
The rest, soft palate, underside of the tongue, floor of the mouth, inside of cheeks and lips that's lined with non-keratinized stratified squamous epithelium.
And the key difference is?
It's much more pliable, it's softer, more vascular, and it moves easily with the muscles underneath. This is what we work with surgically. We can raise flaps of this tissue, move it around, suture it without too much tension because it stretches.
You mentioned the palatine rugae, those ridges on the hard palate. They're part of that tough, keratinized layer.
They are. They help with manipulating food and with speech articulation, part of that fixed landscape.
And keeping everything lubricated, we have the big salivary glands, but also lots of little ones.
Yeah, don't forget the minor salivary glands. They're everywhere in the submucosa, under that non-keratinized lining. Hundreds of them, opening directly onto the surface.
What kind of saliva do they make mostly?
Mostly serous, thin and watery. Like
Right.
the glands in the tongue, it's about constant lubrication and cleansing. This contrasts a bit with the big parotid, which is also mostly serous, and the submandibular and sublingual, which produce a thicker, mixed serous and mucus saliva.
Okay, let's get into the real high-risk zones now, where surgeons need to be extra careful. Starting with the facial features, lips and cheeks.
Right. The lips are built around the orbicularis oris muscle, that circular sphincter. Lots of other facial muscles insert into it to create expression.
And the blood supply is significant.
Very rich.
And
Comes from the superior and inferior labial arteries, branches of the facial artery. That's why lip cuts bleed so much, but also why they heal really well.
the cheeks, forming the sides, mainly the buccinator muscle.
Primarily the buccinator. The key landmark, surgically or in trauma, is the parotid duct. It runs across the cheek, then dives to the buccinator to open inside the mouth.
Where exactly does it open?
Right opposite the crown of the maxillary second molar. There's a little papilla there. If you damage that duct, you can get a persistent salivary leak, a fistula, which is a real pain to fix.
Now, this next point sounds critical, especially for orthognathic surgeons. The key vascular rule for midface surgery.
This is fundamental. The blood supply to the maxilla and the front part of the mandible comes mainly from the facial artery on that side. It gets delivered through vessels inside the bone, the interbony supply, and vessels running on the surface in the periosteum.
A dual system. But this creates a surgical caveat during big maxillary surgeries, like a Lefort osteotomy. Why are incisions limited?
Because when you cut the maxilla for these procedures, you interrupt that internal interbony blood supply to the mobilized segment. Survival of that bone segment then relies almost entirely on the periosteal supply, the vessels on the outside.
So you have to protect that outer layer.
Absolutely. That's why the standard surgical approach, the incision and the upper vestibule, is deliberately limited. You typically don't extend the dissection of the mucoperiosteum much further forward than the first molar teeth. Going further anteriorly risks stripping away too much of that vital periosteal blood supply, potentially leading to ischemia or even necrosis of the bone segment.
Wow, that's a direct link between anatomy and surgical limits.
Yeah.
What about the mandible's blood supply, specifically the front part?
While the back of the mandible relies heavily on the inferior alveolar artery inside the bone, the anterior region around the incisors gets a significant supply from the sublingual artery. This comes in from the lingual, the tongue side.
And this changes with age.
It seems the reliance on the periosteal supply increases with age. As the main interbony artery, the inferior alveolar, might get narrower due to arteriosclerosis, those surface vessels from the lingual and buccal arteries become relatively more important for keeping the bone healthy.
Okay, time to focus on the nerves at risk. Starting up top, maxillary nerve hazards, V2. The infraorbital nerve seems like a prime target.
It is. It provides sensation to the upper lip, cheek, side of the nose, lower eyelid, and the upper front teeth and gums. Its main vulnerability is trauma.
How so?
A direct blow causing a fracture of the zygoma, cheekbone, or the maxilla itself often runs right through the infraorbital canal or foramen where the nerve passes. So numbness in its distribution is a classic sign of these fractures.
And surgical risk.
Any surgery requiring wide exposure of the front of the maxilla, like lifting the soft tissues off the bone through an upper buccal sulcus incision, puts the nerve at risk. You're working right where it exits the bone, so retraction has to be really gentle to avoid stretching or bruising it.
Moving down to the mandible, mandibular nerve hazards, V3. The mental nerve is the big one here for sensation.
Definitely. It's the end branch of the inferior alveolar nerve, supplying sensation to the lower lip and chin on that side.
And its vulnerability.
It's extremely vulnerable in mandibular fractures, especially body fractures, or during osteotomies in that area. The nerve runs right through the bone that's being broken or cut. Displacement almost guarantees some degree of nerve injury, stretching, compression, sometimes even tearing.
And we know exactly where it comes out.
We do. The mental foramen, its exit point, is reliably located on the outer surface of the mandible, usually between the roots of the lower first and second premolar teeth. Surgeons need to know that spot precisely.
One more nerve group, although slightly external. The facial nerve terminal branches. The facial nerve, the muscles, right?
Right, the muscles of facial expression. We're mainly concerned with the zygomatic, buccal, and marginal mandibular branches here.
An injury is a major problem.
Huge problem. These nerves typically run on the deep surface of the muscles they supply. So deep cuts or surgical dissection in the cheek or near the jawline can easily sever them. The resulting paralysis causes noticeable facial weakness or asymmetry, often visible even when the face is at rest because the pull of the healthy muscles on the other side becomes unopposed. All right, let's dive into the floor of the mouth. This area is incredibly crowded anatomically. You've got muscles, glands, ducts, and that very vulnerable lingual nerve all packed in.
Let's start with the structural base, the mylohyoid diaphragm.
Yeah, the floor isn't just empty space. It's a muscular sling made by the two mylohyoid muscles. They run from the inside ridge of the mandible, the mylohyoid line, down to meet in the midline, forming a raphe. This sling essentially separates the oral cavity from the neck structures below.
And sitting within or passing through this sling are the salivary glands.
Exactly. You've got the sublingual gland sitting just above the mylohyoid, right under the tongue mucosa, and then there's the submandibular gland,
which has that unique relationship with the muscle edge.
It does. Most of the submandibular gland is below the mylohyoid in the neck, but its deep lobe hooks are around the posterior free edge of the mylohyoid muscle to enter the floor of the mouth proper.
And the ducts drain where?
The submandibular duct, Wharton's duct, runs forward above the mylohyoid to open at the sublingual caruncle, that little bump on either side of the lingual frenulum right behind the lower front teeth. The sublingual gland has multiple tiny ducts that open directly into the floor of the mouth, or sometimes they join the main submandibular duct.
And what tells these glands to produce saliva? The innervation.
That's parasympathetic innervation, specifically from the chorda tympani nerve. Remember that nerve. It carried taste from the anterior tongue. Well, it also carries the secretomotor fibers for the submandibular and sublingual glands.
So damage the chorda tympani and you potentially affect both taste and salivation.
Precisely. It travels with the lingual nerve for part of its course, which adds another layer of complexity.
Okay, now for arguably the most critical nerve in this whole region.
Yeah?
The highly vulnerable lingual nerve. Why is it so dangerous?
Its location is just treacherous. First off, as it runs forward in the floor of the mouth, it lies directly against the inner surface of the mandible.
How close?
Right up against the periosteum. And crucially, it's positioned exactly opposite the roots of the third molar tooth, the wisdom tooth. At that point, it's covered only by the thin gum tissue, the mucoperiosteum.
So third molar surgery is prime risk time.
Absolutely. Not just drilling into it, but even retracting the lingual tissues to get a better view can easily crush or stretch the nerve against the bone. Or if an instrument slips or a drill perforates the lingual plate, the nerve is right there. Injury leads to numbness, tingling, or even chronic pain, dysesthesia in the tongue and floor of the mouth. It's a devastating complication.
And that's not the only hazard zone for the lingual nerve. It crosses the duct, too.
It does. As the nerve and the submandibular duct run forward, the lingual nerve starts medial towards the tongue, then loops underneath the submandibular duct to end up lateral to it as it enters the tongue itself.
So it's intimately related to both the bone and the duct. This must affect surgical approaches, like for a ranula versus removing a salivary stone.
Completely different strategies needed. A ranula is a cyst related to the sublingual gland or its ducts. The gland sits above the nerve and duct. So the surgical approach involves an incision in the floor of the mouth mucosa. To stay safe, you keep that incision lateral to the path of the submandibular duct, and you absolutely avoid extending the incision too far back, especially posterior to the first molar, because that's where the nerve is most superficial and vulnerable against the mandible.
Okay, but what if you're going after a stone stuck deeper, maybe near the hilum of the submandibular gland where the duct begins?
Then you're thinking flips. You know the nerve is crossing underneath the duct from medial to lateral back there. So, to find the duct safely in that posterior region, your initial dissection should start more medially, closer to the tongue base. You identify the duct first, knowing the nerve will be positioned slightly more laterally relative to the duct in that area. You protect the nerve by finding the duct medially first. It's about knowing that 3D relationship.
That's really intricate.
Okay.
Okay, let's move up to the roof. palatal mechanics and innervation. We touched on the muscles. Most are vagus nerve.
Most of the soft palate muscles, yes. The levator villi palatini lifts the palate. Palatocoryngeus, part of the pharyngeal wall, tenses palpable pharynx up, and palatoglossus pulls palate down, tongue up, forms the anterior pillar. They're all innervated by the vagus nerve X via the pharyngeal plexus.
But the big exception
Is the tensor villi palatini. Remember, first arch derivative. It tenses the palate and opens the eustachian tube. It gets its motor supply from the mandibular division of the trigeminal nerve, V3, via the nerve to the medial pterygoid. Knowing this distinction is vital for understanding palate function and repair.
Got it. What about sensation for the palate? Is it all trigeminal?
Mostly V2, the maxillary division. The hard palate sensation comes from the greater palatine nerve for the posterior part and the nasopalatine nerve for the very front part behind the incisors.
And the soft palate?
Most of the soft palate gets its sensation from the lesser palatine nerve, also a branch of V2. But there's a little bit of overlap at the very back.
Ah, another nerve involved.
Yeah, the posterior edge of the soft palate near the oropharynx also gets some sensory input from pharyngeal branches of the glossopharyngeal nerve. IX. So mainly V2, but with a touch of IX at the back.
Okay, back to the tongue one more time, focusing on its surface and structure. You mentioned the sulcus terminalis as the dividing line.
That's the V-shaped groove on the top surface, the dorsum. It clearly separates the front 2/3, which is technically in the oral cavity, from the back 1/3, which is part of the oropharynx. And right at the point of the V is the foramen caecum,
Which marks?
the spot where the thyroid gland started its descent during development, a little embryological remnant.
Now, the surface isn't smooth. It's covered in papillae. Different types do different things.
Exactly. The most numerous are the filiform papillae. They're small, conical, cover most of the anterior 2/3, and they are fully keratinized, giving the tongue its rough texture.
But they don't taste.
Critically, no. Filiform papillae do not have taste buds. They're purely for friction and general sensation.
So where are the taste bugs?
They're on the other types. The fungiform papillae are the little pink dots scattered mostly on the tip and sides. They have some taste buds, but the real powerhouses are the circumvallate papillae.
Those are the big ones at the back.
Yeah, the 8-12 large circular structures arranged in a V shape just in front of the sulcus terminalis. They're surrounded by a trough. These papillae contain almost half of all the taste buds in the mouth.
Okay, let's nail down that complete sensory mapping again, just to
Yeah.
be crystal clear. V3, 7, 9X.
Let's summarize. Anterior 2/3, general sense, touch, pain, temp, lingual nerve, V3. Taste, chorda tympani pos, posterior 1/3, including circumvallate papillae. Both general sense and D taste, glossopharyngeal nerve, posterior 1/3, including circumvallate papillae. We should probably add that the very base of the tongue, near the epiglottis, gets some sensory input from the vagus nerve X2 via its superior laryngeal branch. But for the main tongue body, it's V3, 7, and 9.
Perfect. Now, the muscles that move the tongue around the extrinsic muscles.
These connect the tongue to other structures. Genioglossus from the mandible protrudes the tongue, hyoglossus from the hyoid bone depresses it, and styloglossus from the styloid process pulls it up and back.
And their nerve supply is mostly straightforward.
Mostly. With one notable exception, they are all innervated by the hypoglossal nerve. Cranial nerve 12 is the motor nerve to the tongue.
Ah, but there's an exception here too, another palate-related one.
Exactly. The palatoglossus muscle. Structurally, it runs from the palate down into the side of the tongue, forming the anterior facial pillar. So technically an extrinsic tongue muscle, but functionally and developmentally, it's considered a palate muscle.
So it gets vagus innervation.
Yes, like most other palate muscles except tensor, the palatoglossus is innervated by the pharyngeal plexus, primarily driven by the vagus nerve X, another key exception to remember.
Now, a crucial point for cancer surgeons. The lymphatic drainage pattern of the tongue. Why is it a warning?
Because of the risk of bilateral spread. While the sides of the tongue generally drain to the lymph nodes on the same side of the neck, ipsilateral, tumors located in or crossing the midline of the tongue can, and often do, drain to nodes on both sides of the neck bilaterally.
Which has major treatment implications.
Huge implications. It means that for a midline tongue cancer, you have to seriously consider treating or monitoring the lymph nodes in both necks, either with surgery, neck dissection, or radiation. Missing contralateral spread can be fatal.
Okay, let's circle back to the dental-velar complex, the teeth and the bone holding them. We said the bone depends on the teeth.
Absolutely. The height, width, and very existence of the alveolar process, the bone socket, is entirely controlled by the presence and eruption of the teeth. The bone forms for the tooth.
So the inevitable consequence of loss.
Is resorption. When a tooth is lost, the functional stimulus disappears, and the body, being efficient, starts to take away the bone that's no longer needed. The alveolar ridge gradually shrinks down, sometimes leaving only the flat basal bone of the jaw.
Which affects everything from chewing to wearing dentures to facial structure.
Everything. And the alveolar vascular supply reflects this. In the maxilla, it's branches from the maxillary artery, greater palatine, infraorbital, posterior, superior alveolar. In the mandible, the main player is the inferior alveolar artery running inside the bone.
That's supplemented.
Yes, supplemented by those periosteal vessels from the lingual and buccal arteries, especially, as we noted, in older individuals where the interbony supply might be less robust. Okay, let's bring all this anatomy directly into clinical practice. How do we use this knowledge to numb things up? Starting with principles of anesthesia for exodontia, tooth extraction.
All right, the common injection for fillings, the supraperiosteal infiltration where you inject near the root tip. It works for the tooth, but what's his limitation for extractions?
Its major limitation is that it does not anesthetize the palatal or lingual mucosa. It numbs the tooth pulp and the gum on the cheek lip side, buccolabial, but not the tissue on the tongue side or palate side.
So if you're taking a tooth out, you need more.
Definitely. You have to elevate the gums off the bone on all sides, so you need separate anesthesia for that palatal or lingual aspect, either more infiltration there or more commonly a nerve block.
Which brings us to the workhorse for the lower jaw, the inferior alveolar nerve, IAN block, injected near the lingula inside the mandible.
Correct. The INM block aims to numb the inferior alveolar nerve before it enters the mandibular canal. This anesthetizes all the mandibular teeth on that side up to the midline.
And it often gets the lingual nerve, too.
Usually, yes.
Yeah.
Because the lingual nerve runs nearby, just anterior and medial to the IM and injection site, the local anesthetic solution often diffuses and catches the lingual nerve as well. This provides numbness for the floor of the mouth and the lingual gums, but it's not guaranteed.
Which is why, for certainty, especially with molars, we talk about the triple threat. What three nerves absolutely must be numbed to extract, say, a lower first molar comfortably?
This is the gold standard you need to ensure. 1, the inferior alveolar nerve for the tooth itself. 2, the lingual nerve for the lingual gum tissue. 3, the buccal nerve, specifically the long buccal nerve for the buccal gum tissue next to the molars.
The buccal nerve is separate.
Yes, the long buccal nerve usually branches off V3 higher up and runs externally to supply the cheek, and crucially, the buccal gingiva of the mandibular molars. A standard IN block often misses it. You typically need a separate small injection into the buccal vestibule nearby to numb it properly. Forgetting the buccal nerve is a common reason for pain during lower molar extractions.
Good point. Okay, let's quickly cover maxillary blocks. We don't usually block the whole upper quadrant like the lower.
Generally not. We tend to target specific branches of V2, maxillary nerve, or rely more on infiltration, which works better in the more porous maxillary bone compared to the dense mandible.
So what are the key maxillary blocks?
For the posterior teeth, especially molars, we often use a posterior superior alveolar PSA block. This targets the nerves before they enter the back of the maxilla. For the palatal side, you absolutely need separate blocks. But the greater palatine block numbs the posterior 2/3 of the hard palate mucosa. You inject near the greater palatine foramen, usually opposite the second molar. For the front part of the palate, behind the incisors and canines, you need the nasopalatine block, injecting into the incisive papilla just behind the front teeth. You can infiltrate the buccal side of upper teeth, but you must block the palate separately for extractions.
Makes sense. Okay, let's synthesize all this with the trauma scenario. Patient comes in, mandibular fracture, swollen face, bite is off, lower lip is numb. X-ray confirms a fracture through the body of the mandible.
Classic presentation. Let's break down the signs based on the anatomy. First, that pathognomonic sign, the hematoma in the floor of the mouth. Why is that so specific to a mandibular fracture?
Is it about containment? The mandible usually holds everything in.
Exactly. The mandible forms a protective trough. When it breaks, that containment is lost. Blood from the fracture site from the bone ends. Maybe the inferior alveolar artery itself has nowhere to go but down into the loose tissues of the floor of the mouth. Seeing that bruising under the tongue strongly suggests the bone itself is broken.
Okay, sign number 2. The paresthesia of the lower lip and chin. The numbness, that's the mental nerve.
Directly related to the mental nerve, remember, it runs right through the mandibular body in the inferior alveolar canal and exits at the mental foramen. When the bone breaks and displaces, the nerve gets stretched, squashed, or potentially even cut by the sharp bone fragments. Instant sensory disturbance.
So the symptoms directly reflect the injured anatomy. Now, the surgical risk. Fixing this fracture, open reduction and internal fixation, or IF, puts that same nerve at risk again.
It does in two main ways. First, just manipulating the bone fragments back into place with clamps and instruments inevitably causes some further stretching or compression on the already injured nerve. It's hard to avoid entirely while getting the bone aligned.
And the second risk.
The surgical access itself. The surgeon needs to make an incision, usually inside the mouth in the lower vestibule, peel back the soft tissues, and place plates and screws. They have to be incredibly careful to identify and protect the mental nerve as it exits the foramen right between those premolar roots to avoid drilling into it, trapping it under a plate, or cutting it during the approach. It's a constant balancing act during the repair.
It really highlights how inseparable the anatomy is from the clinical reality. This whole discussion, from day 14 to the operating room, has been about those connections.
That's the goal. Understanding how development dictates vulnerability, how blood supply dictates surgical access, like stopping maxillary incisions at the first molar, and how nerve pathways, especially that incredibly risky lingual nerve, demand constant vigilance. Mastery is about seeing those layers simultaneously.
Which brings us perfectly to our final provocative thought for you, the listener. We spent a lot of time on how alveolar bone depends on teeth and disappears without them. So, consider this. What are the profound long-term structural and vascular consequences for an elderly patient who needs a large part of their mandible resected for cancer? Think about the combination of losing significant basal bone and the age-related shift towards relying more on that surface periosteel blood supply. How does this double whammy impact the healing, the potential for reconstruction, and the long-term survival of the remaining jaw? That interplay between bone loss, aging vasculature, and surgical intervention is where deep anatomical understanding really shapes patient outcome.